what we've heard about us, I think Lord Coe et al. Did a bit of a publicising campaign for us recently, and it has made a huge difference recently with London 2012, that people no longer need to sort of say, you know, what's Stoke Mandeville about and who Sir Ludwig Gutmann is as well. So recently we've had a huge surge of interest in something that we have actually been doing here since 1944. So the overnight success has taken its time. There's been a big interest in the general public about people who are living with disabilities, and we're hoping that the legacy from 2012 is to show ability rather than disability. And what we really want to do is, what we've always been doing, is what do we use in order to get somebody who's had a complex catastrophic injury back into successful living. In 1944, when Sir Ludwig Gutmann opened the hospital wards just to the, I suppose it's to the west of us from here, he basically said that rehabilitation was successful when you got the person back to paying tax. And really that hasn't altered. But what we need to look at nowadays is how do we continue that to happen and enable people to sort of live their life to the best of their ability. So we've been here since 44. We weren't probably the first unit, but we're the first to have continued to be operational. Because unfortunately, when Gutmann started, people only lived 3 months. And what he did wasn't actually innovative in itself, but what he did, and I think it's what's really important for the theme of this talk, is he used what lots of other people had done and brought it together to make it work. Because one thing on itself is never going to sort of change what happens, but it was actually putting into place all the different technologies that existed then that actually made the difference to the point where life expectancy is approaching that of somebody without a disability. But unfortunately, what it's now approaching is that those with the same problems in the general population, such as heart disease, diabetes and cancer. So we've got people who've had spinal cord injury well enough into the population that we now have to gather with our colleagues to continue to improve life. We've had over about 12,500 people through our doors since that time, so it's not a huge amount of people, but the complexities are huge. And we currently run with about 5,000 people caseload, which is the biggest in the world. We are national for children, but we are regional for adults. And one of the things about it is actually roadside to the grave care. We're involved with people from minutes after they've had their injury to, you know, basically providing end-of-life care. And we hope that there's at least 60, 70 years in that time. It's not a short episode. Because of that, and because of the nature of the complexity of our work, people will leave here. Hospital stay is probably about 9 months to a year, which is far too long, but it was actually 2 to 3 years in Sir Ludwig Gutmann's time. And my colleagues from Australia and America and Canada always laugh when I say that our patients have to travel long distances. Because they think, you know, you haven't a clue. And I said, no, sorry, you haven't a clue, because even a mile on the M25 on a Friday seems a very long time. And that's one of the things, particularly in the southeast, that it isn't just the actual physical distance, it's the time taken to do that. One of the things that Sir Ludwig Gutmann believed right from the start was that, well, really he believed that only he could actually look after patients with spinal cord injury, which was a good way to get started. Doesn't really go down too well with a lot of our colleagues nowadays, but we have the Stoke Mandeville way. But he was right at the start of actually empowering patients to know about themselves, because he said, if you don't know what's wrong with you, don't expect some doctor that's never seen a person with a spinal cord injury to have a clue. So he was right there at the start. And one of the things that we've always done is we've had a physical outreach service that our nurses will go out and visit people either in other hospitals or at home, which, fantastic idea, but incredibly labour intensive. Just a very quick sort of physiology and anatomy, just in case I go into some technical details. Spinal cord injury, it's not just the spinal cord. The spinal cord is really just your sort of part of your master control. network, and if you damage that, it's every single organ in your body that is altered. Nothing escapes if lower than the level of injury. We talk about tetraplegia, which is all 4 limbs, and paraplegia, which is the lower 2 limbs. And the other thing is what people tend to forget, is it's bladder, bowel, sexual function and skin. Everybody wants to walk again, but actually what kills you is a lack of sensation. Because if you don't feel things, you don't know that maybe you've broken a leg, you don't know that you've got a pressure sore. That's what makes the difference. And that's been one of the biggest challenges for medicine to actually assist people to live better, is how do you compensate for that lack of sensation. As I say, where our patients live currently, and I do apologise for this strange looking Scotland, but that's to do with our sort of proportion. And essentially we're really huddled around London, and then we're sort of spreading out. But as I say, we do cover most of the country. We also cover Northern Ireland. We also cover Gibraltar and the Falkland Islands. So we do have some long distances there. But we don't have many patients in the Falkland Islands. But you can imagine doing a sort of follow-up with them. It costs a lot of money, and everybody sort of is happy to go in summer. It's like, please don't get ill in the winter because we're not coming. So, as I say, our patients go from people who've just had an injury, and these are the people that you're likely to see on the kind of casualty in Holby City, because there's lots wrong with them. It looks good for the TV, but it's horrendous when you're the actual person there. Currently, they're probably in an intensive care unit, because the way that we're trying to review how specialty work is done in the UK, not every single hospital can deal with the most complex ill patients. So people will be taken to the equivalent of what we call a level 1 trauma, where you have the intensive care beds, but you won't actually have all the specialties. You'll have the very early ones to keep you alive, but if you don't get the early care for your spine, it can have huge complications later on. So one of the things that we need to look at is how we can actually get to that patient, even if not physically, in order to talk to the patient and their family if we can, but also the treating doctors, who, although may be incredibly experienced in dealing with very traumatised patients with lots of things broken, they're not actually that used to dealing with the complications of the spine. So the patient needs our knowledge right from the start, because people will get the wrong knowledge from people who may be very well-meaning. Some people will either not deal with the fact that the cord injury has occurred, or they will be so bleak about the prognosis. So we do need to sort of get in there early with a realistic discussion about what's going on. We also need to tell people that when they come to the spinal unit, I'm sure you probably put this forward, that it isn't a case of just sort of sitting there waiting for things to happen. It can be very hard work, and it's continuing to sort of redo all the body. We've got a lot of work to be doing. And people do need the psychological support for themselves and their families. And as I say, they need it from people who've gone through the system. So we do like to get peer group support that's there. And just encouragement that, you know, there is life to be getting on with, even for people with very high injuries, those such with the injury like Christopher Reeve would have happened. As I say, 6 to 9 months for people who maybe have paraplegia, and a year for those who have higher tetraplegia. And for people who are actually on a ventilator at the present time, you'll be very lucky if you get out of hospital in under 2 years. And the majority of that time is not actually needed to be in hospital, but we have no joined up way to actually get that person home or in the community safely at the present time. And that's a huge disruption to family and friends, and particularly for those who are parents, to try and keep in touch with what's going on. If it's the breadwinner, if it's somebody who's usually dealt with all the bills and whatever, it's an extra stress and strain not to know what's going on at home. People need a lot of information. As I say, we still believe that the person who knows best is the person who's got the injury, and they have to know that. But the problem is that we're trying to push a huge amount of information onto somebody, and we do know that we're looking at ways of how people can keep in touch with us, to keep up to date, to renew their knowledge, and not just do a general Google search that you haven't a clue what information you're going to get. And the families need information as well. We do run Relatives Day, and it's been absolutely brilliantly received over the past 20 years. But I cannot believe the information I gave to a family 20 years ago is actually current. And we need to sort of say this is a long roadside to the grave process. Families need to update information because their child, which is now an independent adult, or somebody who's now much older, has got to be able to access the information they need at the right time. We do spend a lot of our time teaching. As I say, even though we've been there since 1944, the majority of doctors and nurses and physiotherapists, in fact all healthcare professionals in this country, are actually unlikely to come into contact with people with spinal cord injury. The average GP in this country may have one person with a spinal cord injury essentially on their caseload over their working lifetime. So it's an incredibly complex disorder that people still don't know much about, and we need to know how to get that information over. And although I talk about spinal cord injury because that's my job and that's what I chose to work in, lots of the things that we do actually easily translate to people with multiple sclerosis or strokes, or just people with general immobility problems. So essentially, what do you do? And people say, well, you go into that Stoke Mandeville and you come out and you go off to the Paralympics, don't you? Well, no, actually, there's a few more bits and pieces in it. As I say, it's the whole body that's changed, and the whole part of what we're trying to do is say, okay, what works, what doesn't work, and what do we have that we can actually help you use or help someone use with you in order to compensate for what's not working. And essentially, everything that we do is working on that compensation. And that was fine for probably the first 50 odd years of what we've been doing, but it's time to move on. And what we actually need to really look at now, and we're working with actually sort of changing our thought processes about living with spinal cord injury, is to actually say, well, okay, we can do all this stuff, and that starts pushing you towards the kind of baseline of, okay, you're living with spinal cord injury, but what can we actually start doing that will continue to keep you well and actually may look at improving what the cord can do? We know that the cord doesn't actually stop working completely, but at the moment we haven't really been pushing enough to see how far it will go. And the way to do that will be continuing to look after people, continuing to provide rehabilitation. And unfortunately, the current system of you're injured, you come to hospital and you go home will just not work. So we have to look at how we can actually start providing not just maintenance, but actual therapy in the community. At the moment, we follow up people, we ask them back, and it is still very much based on the, you're doing all right, aren't you? Nothing's falling off, nothing's really bad, see you next year, you know. And we've got to move away from that, moving away from the complications, of which there are many, to actually pushing to, as I say, making it different, making it better. We've been looking at lots of little schemes, but we've not actually been able to work particularly with other partners. Hospital care is very bad for picking up on new technology when it actually means changing what they actually do. And what we are trying to do is to look at working with different partners to provide that care closer to home, but to still have that continuity. I've been involved with the spinal unit for 28 years. And I actually had some emails the other night from a patient I first met 28 years ago who still phones me to say and contacts me to say, not feeling very well, what do you think's going on? And so you do have that lifetime of patient-doctor interaction that we want to continue. So we don't want anything to be faceless. We want it to be, as I say, in your home, in my office, but we want to keep that personal connection there because that's part of the continuity of our service. To say this is the hospital that Jimmy built, public donations back in the 80s. And at the moment, too much of our care is actually based in this physical building. Because the cord affects many different things, it also gives so many different complications. And there's lots of things that we are involved with. So if somebody's talking about diabetes, we're interested. General population would be 4% diabetes, our population 20%. Cardiac disease, unfortunately our patients will get cardiac disease at a younger age than those without a spinal cord injury. So there's actually very little that we don't need to be involved with. So very much we are a bit of a scavenger service. We'll look to see what other people are doing and see how can we actually make that for our patients. And one of the other things that's happening now, and the last speaker talked about it, is traditionally we think of somebody with a spinal cord injury as very young, very fit. That's only one group of our patients. Over the past 10 years, both in the UK and in other developed countries, particularly Canada, Japan, we have a second peak at the 65 to 75 group. And that's the young, active, retired with money, because they've got pension. And they can go out there and buy the Harley that they didn't get before, and they buy the super bike and they go skiing. And they forget that the last time they were on a bike, the engine size was probably a bit different and their muscles aren't as strong. And we do have these very active, young, retired people who end up with a spinal cord injury. And so that's providing a huge new challenge to our service, because we're still looking for the best for these people, but the time and the person that you're starting with is a very different sort of physiological human than the 20-year-old and the 70-year-old. So what do we think about for the future and working with the sort of assistive technology? It does feel at the moment that some of our hospital services are on one side of the canyon, and there's this promised land on the other side with all these amazing things that we can look at. There's a few people that prefer, have got this sort of leap of faith, or maybe not the leap, but just to kind of move towards it. But as a practicing clinician, it's actually incredibly difficult to get to that other side. And one of the things that we've really got to make sure is that it's fit for purpose. Our cupboards are full of equipment that we have bought over the years thinking this will be the next best thing. So hospital services, particularly in challenging financial times, are terrified of buying the wrong stuff. And that's one of the huge problems that we've got to get over. So for us, we want to continue to look after people. More of our patients are living longer, so we have more and more patients with less funding. So we've got to look at how we can do it differently and how we can make it real world. And we do have to cover the information, the education, the keeping people as well as possible, and also sort of getting them better. So just some faces behind what I'm talking about. At the moment, these are people who've got severe injury that they require essentially a large box of tricks which is sitting behind them to keep them breathing. If that stops, they stop completely. They cannot breathe by themselves. If I want to see one of my patients like this in the clinic for anything, the actual complexities of getting them from their home to my clinic is huge. If they come by ambulance, it's an ambulance that will probably be out of service from everyone else for the full day for maybe a 20-minute appointment. The amount of people that will have to come with them, they are never without their own carers, either one or two carers. If they come even by their own transport, there'll be 1 to 2 people assisting them, plus a driver. So, and the amount of equipment, they'll have to bring their chair, which weighs a ton. They'll have to bring suction machine, ventilator, power source, everything. And sometimes when they do come to the clinic, you just think, well, I haven't actually needed to touch them, we've talked, but I've not actually altered anything physically. Why did that have to happen? That come through. You've got a bit of time before lunch, I can show you a little pressure sore, and this is a nice clean pressure sore, so I've been very gentle with you. Now, one of the things that we say, you can put anything you like on a pressure sore except the person. You must keep pressure off to allow it to heal. So why do we then say, well, I need to see how your sore is getting on, and you live in Dover, so I want to see you in clinic, so I say, okay, you have to come by ambulance, you have to come all the way up in ambulance round the M25 and all the sort of time that that's going to take for me to look at your wound and say, well, that's doing really well, keep going. And then you have to go all the way back down. The resources in that is just so ridiculous. And one of the things that we have done is just even using mobile phone technology, we've been able to look at what I see face to face and what I've been able to see on a mobile phone picture, and can I make the same clinical decisions? And it's yes. But it's how do we actually get forward with that? As I say, lots of the follow-up we could be doing could actually be done in a different way. We don't want it impersonal, we want to keep that clinician-patient contact. So we really want to make sure that I can follow my patients up. I don't want to lose them to a different person that sees them all the time. But I can't continue to see people who've travelled all that length of time and used up huge amount of resources to get there. And we're very nosy. So one of the things that, when we're looking at someone, we want to see who's in the background, have they just sort of put a face on to be there? We want to know what the kind of social circumstances are like. At the moment, as I say, people do go out, but it's hugely inappropriate. So how do we actually go forward? And very much as an NHS clinician, I do feel that there's lots of things out there that would be fantastic. But I feel I'm still saying that, and please, how do we work together to actually get through what barriers there are? And what I want to do is not just to keep the status quo, I want to go forward. I want to make people better so that people aren't just sort of living with a spinal cord injury, they're getting better with their spinal cord injury. And that's what we want this telerehabilitation way forward to be. To actually look at not one size fits all, but what will actually help individuals. Some of the long distance rehabilitation that has actually been done in Australia and Canada. And this particular system here is, even in the UK, if you're discharged from hospital and you need a lot of work on your hands, you're not going to get that in the community, because occupational therapists who will spend hours on your hand in hospital don't really have somebody in the community to hand over the ongoing care. So what they did is they actually designed, and there's lots of different things nowadays, they've designed equipment that you can use at home, but people don't use it unless you're being checked up on. So what this particular thing does is that you sort of log in, you can practice as much as you like, but you still have a set appointment time with your occupational therapist in the clinic. So you could be in Vancouver and your occupational therapist is in Toronto, and they can assess by using through the internet link what you've been doing, what you're good at and you keep on doing, and what you're not very good at and you avoid. And so they will then set up the equipment so that when you go to next use the machine, it says, look, you've done enough of the bit that you like, get on to the next part. And that's the sort of thing that we're looking at using. And one therapist can actually be talking to several people. So again, this isolation thing, you're not really working in isolation, because the individual patients throughout Canada in this particular thing could talk to each other. And that's part of it, saying, you're still useless. And, why haven't you got any better since last week? And I've got, a higher injury than you and I can still do better. The usual things that get people going. Not that our patients are competitive at all. And the next thing about this getting better is, one of the things that we need to be doing with people is, you can't just go home from hospital and not do anything. We do know that the more that you actually stimulate the muscles and the nerves, you can continue to get changes and functional improvements. We see this a lot with children, but even with adults, it looks like we can sort of continue to stimulate the cord. If the hype is just hype, what we do know that if you actually continue to exercise using one of these particular machines, which is an electrical stimulated bike, and this lady would be paralysed from the waist down, the actual movement of doing this will actually help your skin, your blood flow, your bone metabolism, your heart and your lungs. So if it doesn't do anything for your cord, it's actually still giving you extra years of quality life from the other medical conditions. Again, with this, we can have people all around the world, and it's all linked in to an office with the specialist who will sit, and he will read all their different biological markers. He will look at that nerve's now working that wasn't working before, or else you're overstimulating, and they can change. We use this a lot, and sometimes patients will come off the session just saying, that was dreadful, that was awful, I don't know what's wrong with me. So we phone up and we said, oh, that's a dreadful session. We said, oh, that's good, I made it harder for you. And so they can actually adjust it from, from wherever they are. I do feel they should be telling people a bit more rather than putting them through the kind of, you've not done so well today. But this is one of the things to actually continue for people to be in their home and do it. Problem with this? It's £17,500 per person for the lower leg ones, and if you want to put the arm working on it, it's probably another it's about £20,000. But there are more simple things, and our patients are very technologically advanced. We've had from the start from mobile phones coming in, people phoning from the bed to say to the nurse's station saying, can you come and get me a drink? I'm lying in bed. We get people who will email us from the bed to our office. So people do want to be involved, and they will use whatever technology that they can get into the hospital to contact, to ask, and to keep in touch. So why isn't it happening? We're talking about it, we want it to really happen. And so lots of the things are why isn't it happening? Our adults aren't afraid of technology, but they do want to know who they're talking to, and they do want to have trust in that person. So we've got to get it right between what works best and who's involved with it. It's interesting that 90% of all interactions in healthcare are face-to-face, and even a 1% reduction in that would save up to £200 million, and that's for 2012 figures. So for us in particular, we could have good quality interaction with our patients. There would be huge savings, and that would allow us, we hope, to see more patients and to move away from just fixing things that are broken to actually move into more preventative care. I'm just going to go through, I'm sure you know why technology is there, but I think one thing is to look at the collaboration and to actually look at the efficiencies which are just staring us in the face to do. We do have a lot of Luddites, I think, within the medical profession that, you can't do that, nothing will get better, it won't work, people have got to come and see me. But I think something like this whole system demonstrator has shown that it is possible to make a difference. For us, one of the problems has been hospital IT. They feel very much it's not their job. Their job is to do patient administration systems, and all the rest of it, that's not us. So it's a case, well, who is going to do it? And who's going to pay? If I see somebody in the community, does the hospital say, we're not paying for it? And the community says, well, you used to do that, why can't you keep paying for it? And these are big, big changes that we've got to look at. And just before I go, I'd just like to say, I'm a bit too sort of, well, why can't we do this and what should we be doing? But I think we do have to remember that technology has actually got us a little bit forward.